Inside many specialty clinics, a diagnosis is just the beginning of a long administrative fight. The current prior authorization system often feels as if it is engineered to delay approvals rather than deliver care. This chart displays the scale of that burden. Data from the American Medical Association shows that the average practice completes 39 prior authorization requests per physician every single week. Managing that volume requires 13 hours of work. That means staff spend nearly 2 full business days every week focused solely on administrative tasks. This creates a direct financial drain. Peer-reviewed research indicates this administrative time costs clinics approximately $82,975 per physician annually. To manage this, 40% of physicians now employ staff who work exclusively on authorizations. The strain is also psychological. 89% of surveyed physicians report that this paperwork burden contributes directly to professional burnout. The prior authorization system acts as a structural drain, cannibalizing the resources necessary to run a specialized practice. Even when everything goes right, the Pharmacy Benefit Management Institute found that a single specialty medication request takes 3 to 5 business days to process. In pediatric medicine, these timelines carry a much heavier weight. A child waiting for growth hormone therapy or specialty medications for endocrine disorders is not simply waiting for paperwork, they are waiting for treatment. In this environment, an administrative backlog is a direct clinical cost paid by the patient. To see how these delays happen, consider a pediatric endocrinology clinic in Port Saint Lucie, Florida. The clinic manages complex treatments, including growth hormone therapies, continuous glucose monitors, and insulin pumps. These treatments require detailed clinical documentation, multiple lab results, and peer-to-peer reviews. It cannot be handled with a simple checkbox. At the Florida clinic, fax queues inside their e-clinical work system were constantly backing up with denial letters and information requests. Staff members who were originally trained to coordinate pediatric care were instead spending their hours chasing payer approvals. This reactive management style often leads to missing documentation gaps, which results in higher denial rates and longer wait times for children. Staffingly addressed this by deploying a dedicated, embedded team accountable to this single practice, rather than using a shared pool of workers. The team avoided any workflow disruption by working directly inside the clinic's existing e-clinical work software. They moved the clinic to a proactive model, gathering and submitting documentation before the authorization window even opened. The financial contrast is significant. An in-house coordinator costs between $38,000 and $50,000 annually. Staffingly's model operates at $8 to $10 an hour, representing a 60 to 70% reduction in cost. In November 2024, the practice director posted a 5-star review, stating the partnership completely overhauled their workflow. By combining proactive management with direct EHR integration, the clinic turned an administrative liability into an operational advantage. Within weeks, the clinic saw faster turnaround times and a measurable increase in authorization approval rates. Most importantly, the clinical staff was finally freed from the paperwork spiral to focus entirely on their pediatric patients. This model works because dedicated specialists build the deep, payer-specific knowledge that rotating administrative staff rarely achieve. The success of this approach is built on 3 specific operational requirements: dedicated oversight, proactive documentation, and direct EHR integration. The system is built on strict compliance standards, including HIPAA, SOC 2 Type 2, and HITR US certifications, all managed through a month-to-month contract. Effective specialty care requires moving beyond broken, in-house administrative systems.